So just to quickly introduce our speakers, we have Associate Professor Nicholas Wood and Lauren Dalton. So Nick Wood is a Staff Specialist General Paediatrician and Associate Professor, Sub-Dean Postgraduate Research in the discipline of Child and Adolescent Health at University of Sydney. He holds an NHMRC Career Development Fellowship. He leads the New South Wales Immunisation Specialist Service and coordinates the Immunisation Adverse Events Clinic at the Children's Hospital at Westmead. He is interested in maternal and neonatal immunisation, as well as research into vaccine safety and the genetics of adverse events. And Lauren has a background in public health and has been working at NCIRS since 2017 and currently manages the PHN Immunisation Support Program. Prior to this, Lauren was working at Central and Eastern Sydney PHN and SES Medical Local and the Royal Australasian College of Physicians. Lauren has been involved in a number of data quality studies relating to Australian Immunisation Register, also known as AIR. So let's go over to Professor Nick Wood to start the presentation.
Hello everyone. I hope you can see the on the screen now the slides. So we'll just try in a little while next. I know how busy you all are. We'll just try and update you on the flu story for this year, a little bit about what happened last year, talk about the changes with pneumococcal disease, and then finally a little bit on catch-up immunisations. So I think if, as Mimi mentioned, if you have any questions, you can type them in as we go along. And if we can't get to them, then certainly let Mimi know and we can try and answer them after tonight's webinar as well. So the 2019 flu season, it was a pretty big one for Australia. And the next slide sort of shows the number of lab confirmed notifications. This shows the years 2013 to 2019. And what you can see, what a little bit it was unique about the 2019 story is that it came a little bit earlier than previous years, and so it sort of peaked around about June, July, which was ahead of our normal August, September peak. It was a more longer and flatter season than previous years. What this means for this year, we're not quite sure, because with the social distancing that's happening at the moment, there's less likely to be spread of respiratory viruses across the community. So this could be a different year. And what it does tend to do is be a high year one year and a low year the next year. So we're not quite sure. This was a bit more data about the 2019 season, and I think the things that to stand out here is that the bulk of it is an A type disease. Some of it was B, but the bulk was A. In terms of the vaccine effectiveness, this data comes from what's known as the FluCan PEDS hospitalisation system, which is a surveillance system across the country, and we look actively at hospitalisations for flu. We compare that to controls, and using the case control method, we come up with the vaccine effectiveness. And you can see here that overall the vaccine effectiveness was around about 45%, a little bit higher for H1N1, and it's always a little bit lower in H3N2 and a little bit lower in the elderly, but pretty good in the children, nearly 60%. In terms of safety, this is the 2019 data from what's known as the AUSVAC safety system. And this is again an active surveillance system where we survey, usually by GPs, using the system which sits in the back of their best practice or their medical director systems, is active surveillance for flu reactions. And you can see overall around about 6% of people were reporting any adverse event. At the green bar, which is the medical attendance, the more severe was less than 1%. And in the pregnant women as well, it was less than 1%. So that was a good sign that the vaccine last year was performing as predicted and has done in certainly in 2018. And we will do the same again this year with the Authvex safety system. This is a bit more data on the pregnant women. You can see there 95% plus of the 3,700 women who responded had no adverse events. 5% reported any reaction, and only 0.5% reported going to the GP. And the commonest things were injection site reactions, a bit of tiredness and headache. So not too worrying. Ausvax safety website, which you go on to that, is a good tool to use, hopefully when you will be vaccinating people who ask you, how is the vaccine performing? The good thing about this website is it's updated in real time, and so you should see the 2020 data as we start to vaccinate appear on that website, and so you can show people very quickly how this vaccine this year is going. So the brands that the antigen content for this year, nearly all of the vaccines are a quadrivalent one now. So that means 2 A's and 2 B's, and you can see these are the strains that have gone into the 2020 vaccine. Some key messages for you. All the vaccines available this year are quadrivalent. Anyone aged 6 months to 5 years now can get an annual flu vaccine under the NIP. Previously, states and territories were funding it, but now it's under the NIP. And the dose for the flu vaccine for all ages is 0.5 ml. The 0.25 ml, which we use for the younger kids, is no longer available. And for the over 65s, the vaccine that you should be using is the adjuvanted one, and the Fluad Quad is, and I'll show you a bit more of that in the next table as we go on. So who should get it? Those aged 6 months to 5 years we talked about. This is a newly eligible group. Any Aboriginal and Torres Strait Islander person over the age of 6 months, pregnant women over 65s, and then anyone over the age of 6 months that has a medical condition which increases the risk should get it, and these are the NIP funded ones. These are the brands by age. You'll note that the Fluad Quad, which is the one for the over 65s, is the recommended because it's the adjuvanted vaccine, but they're all the quadrivalent this year. So, and the other change to note is that this younger age group, the 6 months, it's a 0.5 ml dose across the board. Okay. So when's the best time? Well, now it's available, really now onwards, but don't stop offering it. So in the context of our current pandemic, those with chronic conditions, what we don't want is for them to have both flu and COVID. As I said, I can't tell you how much flu we're going to get. It may be less than previous years. Particularly those over 65s, pregnant women, children when they turn 6 months of age. They've now got a bit of a window there because you're really only giving the one vaccine because the pneumococcal has moved. And the optimal protection, we believe, does occur within the first 3 months. Now, as we showed you earlier, in 2019, the first 3 months was, in fact, May, June, July. So it's probably, you know, the argument to say, should you wait for the flu season to come later in the year? Well, in 2019, it was probably better to get the vaccine in April rather than waiting. And we say that the vaccine should continue to be offered as long as the flu viruses are circulating. What about a second dose? Well, in general, a single dose is recommended. However, those that are aged 6 months to 9 years who are getting the flu vaccine for the first time, they should get 2 doses. And anyone giving a flu vaccine for the first time after a transplant or stem cell transplant or solid organ transplant should also get 2 doses. Now, people often say, well, should I get a dose now and then get another dose later in the year? The party line to that one is that it's not contraindicated, but it's not recommended, and it may be of benefit for some individuals. And this could be, for example, the person that gets it in April now, and then if once pandemic is all disappeared, they're going off to the Northern Hemisphere at Christmas time, then there could be an argument to give them a second dose. And certainly for pregnancy, if the pregnancy spans 2 flu seasons, they should get the 2 vaccines. So we're talking a little bit about pregnancy now. It's recommended in every pregnancy in any stage, and you can certainly give it safely at the same time as the pertussis vaccine. So if you got the 2019 vaccine towards the end of last year and you were pregnant, you should still get the 2021 now. So you're effectively getting 2 doses whilst pregnant. And the reason for that is that the main benefit is not only for mum, but also for the baby with the maternal transfer of antibodies. For the over 65s, as I mentioned earlier, we really want to recommend the adjuvanted one. Okay, it's as we said before, they're all QIVs, but the adjuvanted one just produces a better immune response. The Fluzone high dose, which was previously supplied, is no longer available this year in Australia. And if the Fluad Quad is not available, when someone says, look, I really need to have this flu vaccine, and you've only got the standard dose one, you can give it. But I don't think there'll be much trouble anyway, so really waiting for the Fluad Quad is the better option there. How do we go in terms of coverage? Well, this is data from last year. Just over 12 million flu vaccine doses were released. Around about a quarter of our population, nearly 6.7 million Australians, recorded having had a dose of the flu vaccine on the register. Probably most reliable in the younger kids and the older adults, because that's what practitioners are used to recording. So probably less reliable in those aged, 5 years to say 40 years. And there was an article last year in the MJA which said that we've got some room for improvement. So message for you guys, which you're going to do anyway, is if you do give a flu vaccine, get it onto the register so we get a really good accurate estimate this year. Some of the frequently asked questions about the flu vaccine. If you've got a latex allergy, can you get the flu vaccine? The answer to that is yes. The flu vaccines used in Australia are latex free and therefore safe. Does the flu vaccine always work? Well, as I showed you earlier, not always, but it does reduce your chances of getting a nasty flu, particularly a hospitalised flu, by about a half. And the other thing it does is it might give you a milder disease and therefore make you less likely to spread flu this year. So another question, if this is the one which we often get asked, is should patients receive 2 doses of flu vaccine in 2020 if they're getting the initial early dose this year? I sort of answered that. It's not routinely recommended except for the pregnancy group. I know some people give it to the immune suppressed, but it's not routinely recommended to have 2 doses in a single year. Are we able to give the flu and childhood immunisations at the same time? The answer to that is yes. There's no contraindication to giving them both at the same time. This is another question which we sometimes get. If the child who was getting their first flu dose in 2019 was supposed to get the 2 doses, but they didn't, they only got the 1 dose, and now they're turning up for their 2020 dose, should they get 1 or 2 doses? And the answer to this question is just give them the 1 dose. Don't worry about having to give 2 doses. Just say last year was their first go, even though they didn't quite get the right amount of doses. This year, just give them the single dose. Even if last year they just got the 0.25 ml dose, just give them the single dose this year. And the next question which we sometimes get is, can flu vaccine be given to a patient who has a significant risk of egg allergy? I think that's what it says. I can't quite see because there's a box in the way. But if you do have an egg allergy, yes, you can safely get the flu vaccine. So this came up a little bit because people were saying, well, what about a 2-year-old who last year got the 0.25 ml dose and has egg allergy? This year they're getting a 0.5 ml dose. There potentially is a bit more ovalbumin in it. Is it still safe to give? Askia and has put out on their web that there's usually less than 1 microgram of ovalbumin in the flu vaccines, and therefore it's safe to give the flu vaccine to egg allergic people. There's a whole lot of resources that will be available on the New South Wales Health website, if you can find them amongst the COVID story. Other resources are shown here from the Commonwealth. Direct you to the Sky website if you get a chance, which is Commonwealth funded and NCIRS initiative. It's very useful, and there's a very good website called Talking About Immunisation, which has a lot of fact sheets on it for parents and for providers as well. Okay, so moving along a little bit about COVID and pneumococcal disease. I suppose the bottom line is that the influenza and the pneumococcal vaccines really not going to give you any protection against the SARS coronavirus 2, but what they will do is stop you from getting flu and hopefully not COVID, but they stop you from getting a co-infection. So that's really the important point to take home. I think I understand from the PHN that there has been a bit of a restriction on access to pneumococcal vaccines, because we do really want to make sure that they're available for those that are at the high risk groups because of their medical conditions. And so there probably will be a little bit of limited supply, I understand, from the State Vaccine Centre for that. In terms of, you probably know a lot of this information anyway, but the viruses are quite similar. They both can cause, fever, cough, trouble breathing. They do, as we've seen, need good hand hygiene, respiratory etiquette, and hopefully the social distancing will reduce both of them this year. This is a bit more information for you to take away to compare the two viruses. Importantly, the R number, which is the number of secondary cases, is unfortunately a bit higher in SARS CoV-2 compared to flu, and the mortality rate is also higher, unfortunately. Interestingly, children appear to have lower attack rates and less severe disease, which is a contrast to the seasonal flu vaccine, seasonal flu virus, where children can get very sick with it and end up in ICU. And unfortunately, we don't, as you know, have any specific treatment for SARS-CoV or a vaccine yet. There are many vaccines in the pipeline. There's about 50 different vaccines underway. There's a trial in the US with the Moderna vaccine, which is an RNA vaccine. An Oxford group also has a vaccine which seems to be in clinical trials as well. But there are about 40 different approaches being taken for that. This is some more details about the comparisons of COVID, cold, and the flu. I suppose again, it's very hard for you in GP land to really tease these out, unfortunately, and that's part of the problem with managing this pandemic. You've probably seen from Mimi earlier, there's a lot of information on the PHN website. There's Commonwealth Health Department, New South Wales Health Department tracking these things on a daily, weekly basis. There's quite a nice website called COVID-19 Data, which is a non-health one, but does have just and trying to accurately describe the number of cases. A little bit of good news is I think the cases have certainly just appeared to be on the downturn for a little bit, the last few days at least. I won't go through this in any detail, and this is just more information for you to read later on. And again, the information here about the AHPPC, which is the advisory committee to the Prime Minister. They are, using modelling at the moment to work out what to do with the social distancing. So, a couple of questions that we've had is, having this current pandemic, does it change when or should you get the flu vaccine? No, you should still get the vaccine and ideally try and get it now. The problem, I suppose, is particularly for you guys at the front line, is how do you do that by maintaining the social distancing? And there's a little bit of information on the New South Wales Health website, which I don't think you'd be able to read, but certainly worth you having a look at. There's some recommendations for the venues about how to run the vaccination clinics. There's some more information about the social distancing, how to set up the clinics. At the kids hospital, our clinic is just one parent and the child at any one time in the room. And the key thing also is to, pre-screen people to say if you've got any particular symptoms, then you should not turn up on this particular day. So there is a risk, or there's a concern that vaccination for routine vaccines might fall because of the pandemic, and so that is a worry, and it is hard for you guys at the front line. But there's a little bit of help out there in terms of how to set up the clinics. One of the questions we've got is, are we seeing more community acquired than overseas acquired? Certainly, up until recently, they were definitely more overseas acquired ones than community acquired, and that's really what informed the modelling about shutting the borders. But now the modelling is being done again. There's a range of transmission studies underway around the community to understand how much is spreading from one person to the next within the community. I can't really answer the next question, I'm sure, sufficiently, which is how do you really screen these patients? So people online have got some good ideas, then certainly worth sharing them with the group. I've talked a little bit about the vaccine development. There are about 40 different candidates in the pipeline. I think it's going to be at least a year. One of the concerns is that the vaccine could potentially result in an enhanced immune response if you were to get the exposure to the real virus, and so that's probably going to be a thing that will need to be very closely studied. That was seen in previous versions of the SARS and MERS vaccines in the animal model, and so it's one of the concerns that we might be giving someone a vaccine but then effectively priming their vaccine for a more enhanced antibody-mediated response when they see the real virus. Okay, so it's been a bit of a gallop through the whole, setup. A little bit on catch-up immunisations. Just to direct you to the handbook, which has a very good section on it now. There's a catch-up app in development as well. In general, there's some sort of principles. The scheduled intervals between the doses, there's usually a minimum interval of about a month between doses, and generally as you get older you might need less doses of things. The other thing to think about is as a person gets older they are less vulnerable to specific diseases and therefore they don't need vaccines, and a really good example of that is the rotavirus vaccine. Just the point here that incomplete or overdue vaccines, you should just using what obviously you're going to do that, use what vaccines they've had in the past to design the next schedule. And you can give one dose of each due or overdue vaccine at the first catch-up visit. And as we talked about, there is an appropriate minimum interval. Standard intervals, and the program in the National Immunisation Program schedule does define this for us. We can give inactivated vaccines at the same time, but for live vaccines, they should be given either at the same time or separate by a month. And there are specific recommendations in the handbook about that. Just a note here that, as you already know, immunocompromised people should not receive live vaccines. This is just a point to say that if you had to give a meningococcal C at the same time as, for example, a combination one with the same antigens in it, that's okay, but probably preferable. And if there's only that vaccine available, then you can give that. And that's, for example, where the same antigen is given in two arms, you need that for the combination. The handbook has tables and resources. Just direct you to these. Definitely have a look at those. There's some quite nice diagrams about where to give the particular injection. Immunisation schedules, I won't labour this point, they're all available on the New South Wales or the Commonwealth websites. There is, as I mentioned, a new catch-up app being developed. This is an example of a catch-up schedule, which is for a child who's 4.5, not Aboriginal and Torres Strait Islander, and they've actually really only had one dose of the vaccine. That's the Influenza Hexa, Prevnar, and Roderick, so that's really dose 1 of those and was given at 2 months. You've scanned the practice records, the register, and you've asked the parent about the previous immunisation, and you can't see they've had any more, and therefore you go on to do a pre-screening checklist. And this is, for example, of what you could plan to give at that particular visit. If the parents were happy, you could give the 4 vaccines, and then, you know, the Influenza IPV, MMR shown here. MMR and MMRV separated by at least a month because they're 2 live vaccines. So that's just an example. There's a lot of detail here, and there are lots, just to point out, there are lots of fact sheets for those under the age of 20, those that are refugees and humanitarian entrants as well. Consider for adults the halo idea. So that mentioned, shown here, particularly things for the occupational type ones, such as varicella, hepatitis A, and Q fever. So there's, again, very nice descriptor in the handbook about that as well. Some questions here which I'll come to. Pneumovax 23, I've got a bit of a slide on that one. I'll show you in a second. Why is there a limit to the booster of the 23 valent? And bear in mind that what we will show you about the pneumococcal schedule may well change. There was a public consultation document which closed just about a month ago about changes to the pneumococcal vaccine schedule, so there could well be some changes coming very soon. May not be July, given what's happening with all the COVID story, but potentially. Will New South Wales get Bexsero vaccine on the schedule for infants? I might have had a different answer to that 4 months ago, but I think right now the answer will probably be no, it won't get on the schedule. So this is a very busy slide, and I think what it highlights is how complicated pneumococcal vaccines are for adults. And so if you do go to the handbook and look in the pneumococcal vaccine section and look under recommendations, there's a whole lot of tabs that you can click on. And I think what's important to think about is that there is this 13 valent pneumococcal vaccine appearing in the recommendations for adults. And it does vary a bit according to category A and B, and that's where it becomes very complex. But there's this idea of giving the new adults with newly identified conditions a single dose of 13 valent and then 3 doses of 23 valent. In general, we like to give 3 doses over your lifetime, separated by about 5 years in general. But I think rather than going in, it's so complex and each condition recommendation can be quite unique, my advice would be to go to the handbook, and it is tries to be spelt out quite in a quite useful way, hopefully for him. So tips for vaccines: don't delay them, don't separate the doses, try and get opportunistic vaccine, think about the free measles vaccine, encourage the flu vaccines, discuss vaccines with pregnancy about the soon-to-be parent, including the father, try and get adolescents up to date, and the over 65s with the pneumococcal vaccine. Flu vaccine is out there now. I know it's hard to get into for some people to get actually into the clinics, but it is one we want to try and get in as much as we can. And then there's a little bit, I think, just go to that New South Wales Health website, which gives you some information about how to approach the vaccines in the pandemic setting. Particularly acknowledge Lauren and Cheryl, who did all the hard work with this particular talk. So that's it from me. Mimi, I don't know whether I'll stop showing the screen and we can go back.
Hi, everyone. So we're just going to do a few question and answers with Nick. So people have submitted their questions through and we've collated it. So the first question is, if a patient has gotten the influenza vaccine early and they wanted to get a second dose, would this second dose be free?
I think the answer to that is no, it would not be free, particularly if they got one free dose as part of the NIP. So the NIP is not funding 2 free doses for those that are at risk.
Okay. Second question is, if a 65-plus-year-old patient got the flu vaccine at a pharmacy early because it wasn't available at the GP, and this vaccine was the non-adjuvant vaccine, should they still go and get the Fluad quad from their GP? And if so, how long should they wait before getting the quad Fluad?
Yeah. So I think this is the question. I tried to answer that before. They don't necessarily have to have it. Probably, you know, I might get into trouble here, but probably not going to hurt them to have it. But it's certainly not routinely recommended. And I suppose if they're paid for the first one, then the second one would be free under the NIP, and a minimum of a month between those 2 doses. But it's not routinely recommended. Okay. So I don't think they need to worry if they can't access that Fluad quad. They've had a quadrivalent vaccine, they just haven't had the adjuvanted one. I hope that answers okay.
The next question is, are obesity and hypertension part of the medical risk conditions for eligibility of funded flu vaccine?
I don't know whether Lauren's online and she can help me answer that one. I think I've heard different answers to this. Are you there, Lauren, and able to answer that one?
I am. I'm just going to look up the handbook and check, but I think the handbook would be the best source. But if you go to the next question, I'll just have a look if I can find it.
Okay, we'll skip ahead and then we'll get back to that question. So these next few questions will be on pneumococcal. Should we be giving a booster every 5 years for the pneumococcal vaccine?
Yeah, and this is where it gets complex, and I think I tried to show it in that slide with the listing of all the different categories. It depends a bit on which category they are, which age, have they had previous pneumococcal 23s, but in general it's up to 23 valents and separated by about 5 years. You don't want to keep giving them every 5 years, but it's usually up to about 3 pneumococcal 23 valents. But it does a little bit depend on the categories and the age at which they've had a prior dose, etc.
Next question is, can adults who are over 65 years old, who have medical conditions that put them at high risk, can they get a second dose of the Pneumovax 23 for free?
I think they can, the answer to that, but this is, I'm pretty sure they can as part of the NIP. I think that's right.
And the next question is it safe to have Pneumovax, Zostavax and Fluad Quad all together in one visit?
Yes, it's safe. You can do that. If the person's happy to have 2 inactivated and the Zostavax all in the one go, yes, it can be done. You might want to probably, you know, in practice, would I probably give 3 at once? Probably I would split them up in practice, but it's safe to do. If you think they're not going to come back, then yes, you can give 3 in one go.
And these next questions are just under the other category. Should we use alcohol swabs to clean the skin before injections and vaccinations during the COVID-19 period?
Good question. I think probably the answer, I haven't seen any information recommending you should do that. I think, you know, in the past we haven't used recommended alcohol swabs. I think just, you know, giving vaccine using gloves, needle in and out, not necessarily use the alcohol wipe. As I said, I haven't seen any recommendations to do so. If you do it, then you need to make sure the alcohol dries before you give the vaccine, because there was theoretically, if the alcohol is still sort of moist and wet on the skin, that it could inactivate the vaccine. So my thoughts would be use the glove when you hold the arm to give the vaccines, but not necessarily using the alcohol ones.
Next question is, can health workers or clinical placement students receive free government flu vaccines and the 2 doses of funded MMR?
Yes, to the 2 doses of MMR, yes. What did you say? The other one was the 2 doses of flu vaccine?
Oh no, 1 dose of flu vaccine plus 2 doses of MMR for health workers and clinical placement students.
Yeah, yes, definitely for healthcare workers. Frontline health workers should get the free flu vaccine. I'm not sure about the clinical placement students if it's free, but certainly the 2 doses of MMR is free in New South Wales.
With the social distancing and coronavirus, is it likely that we will have a mild influenza season? Hello? Nick?
I didn't unmute myself. We know that flu is similar to coronavirus in that it spreads through respiratory droplets. Hopefully the fact that we're all a bit more spread apart will mean there's less transmission. Social distancing is certainly recommended as part of flu pandemic responses. So hopefully we will see less flu because of these measures. In general, we will, you know, 2018 was a low flu year, 2019 was a big year. It could have been a low flu year this year, but I hope we do see a low amount.
Next question is, patients feel they may be protected without the vaccine. What are your thoughts?
Protected without the flu vaccine?
Yeah, patients feel they may be protected without the flu vaccine. What are your thoughts?
I think it's better to get the vaccine than not. As I showed before, effectiveness depends a little on the age, it depends on the strains, but last year it was around about 45% protective, a little bit better in kids, a little bit lower in the elderly, which is what tends to be, or bounces around from year to year. So if it's 50% effective, then that's better than nothing. So certainly what we really worry about is protecting you from hospitalisation. So my thoughts would be to get the vaccine rather than not.
Next question is, will the speakers provide a copy of the slides if requested?
Happy to, yes.
Is there a greater risk of febrile convulsions in children receiving the 12-month immunisations, including Prevnar?
No, we've looked into this and there's no increased risk by having Prevnar added on to the schedule. There was a bit of a story in the US where they were giving the MMRV at 12 months and they're also combining flu and Prevnar, and that resulted in increased risk. But in the Australian setting, when we've looked at it, there's no increased risk by the addition of Prevnar at the 12-month mark with the MMR.
And having your seasonal influenza vaccine at the 12-month mark with the Prevnar, would that increase febrile convulsions?
Yeah, look, there's a theoretical risk that it might do a little bit increased risk. I suppose you could, the only option really is to separate it out by a couple of weeks to a month. I probably wouldn't recommend doing that. I think, if people come in for this one chance to get the vaccines, better to get the vaccines in than to not. If you're going to see a fever from flu and Prevnar, it will be somewhere in the 48 to 72 hour mark after that vaccine. So if a child has a risk of febrile seizures, just warning the family that the fever, if it comes on, will happen in this 48 to 72 hour mark. Look out for it, give some Panadol, and then that should reduce the fever and hopefully less chance of a febrile seizure.
Our next question is, if someone is to have 2 doses of flu vaccine in 2020, for example, pregnant women, what would the recommended gap be between the 2 doses?
Oh, so if you're again, it depends a little bit on when they're going to deliver, but if they're going to deliver before the end of the flu season, I would just give 1 dose now, and then that's it. If they're going to be going pregnant into the 2020 year, so 2021, then they should have a 2020 dose because they're pregnant now, and a 2021 dose. But if they're going to deliver this year, then just give them the 1 dose. They don't need 2 doses.
I think with that question, it's more like if you're finishing your pregnancy in, say, April, so you'll get the 2020 dose now, and then you give birth, but then you get pregnant again in 2020, will you get the same vaccine in 2020 for the second baby?
Probably not in that case. I think what I would do then, if they're going to get pregnant that quickly again, I would probably just give them wait till the 2021. So if they're delivering now, then and I suspect they, might get pregnant. I don't know, but I would have thought at least 6 months after that. So that wouldn't be until the end of the year. Then I would be giving them the 2021 vaccine.
Next question is, on the schedule, it is recommended only 1 pneumococcal vaccine. Can you please confirm?
So for the over 65s that are healthy, yes, just the 1 pneumococcal vaccine. Where it becomes complicated is when they're over 65 and they have different category medical conditions, and therefore they need either 13 valent plus extra 23 valent vaccine.
And the next question is, how long after getting a flu vaccine will you be protected?
In general, we think the vaccine protection lasts about 3 to 4 months. It wanes after that. So as I showed you last year, it peaked in June. So getting the vaccine now is sort of really important, because if it peaks early again, then your vaccine's working really well. So it's in general, immunity wanes sort of 4 months after the vaccine.
I think with that question, perhaps someone's asking, how long after you get the flu shot will you start becoming protected? Is it straight away?
Oh no, it takes a couple of weeks for your body to make antibodies. So yeah, you would, if someone sneezed on you that following day with flu, the vaccine you just got wouldn't probably help you. So it takes a couple of weeks for your body to make antibodies.
And there's another, I think it's the last question. People who miss their HPV second dose or third dose for more than 1 year, do they need to restart dose 1 again?
No. So do not restart the schedule. That's one of the principles of catch up. If you've had 1 dose, you can count that as a valid dose and then carry on. So if you've had 1 HPV in the past, you just need the 1 more of the 9-valent to complete that schedule. No need to restart.
And does that apply to other vaccines such as varicella, MMR, Hep B, etc.?
Yes, it does. Yep.
Well, that's all the questions. So thank you so much, Nick.
That's okay.
Before
Thank
you
you.
go,
Yes.
Yeah, I can just clarify the eligibility for those who have certain medical risk factors. So just on the Australian government website, I'll just read them out. So eligibility for a free flu shot with those aged 6 months and over with certain medical risk factors as follows. So heart disease, severe asthma, which is defined as requiring frequent medical consultations or use of multiple medications, chronic lung conditions, diseases of the nervous system which affect your breathing, impaired immunity, diabetes, kidney disease, and children aged 6 months to 10 years on long-term aspirin therapy, and hemoglobinopathies, if I've said that right. So that detail, and I can send you the link, is those who are eligible for a free vaccine with those chronic conditions. So I think the question was around obesity. So unless somebody's got obesity with one of those risk factors, then no, they wouldn't be eligible.
Yeah, the question originally was obesity and hypertension, are they part of the medical risk eligibility for funded vaccine?
Yeah, so I'm happy to send that link through with that clarity for those people.
All right, thanks for that, Lauren. So we'll switch over to Lauren for the second part of the presentation, and Lauren will be speaking.
Thank you.
Thank you so much, Nick. Lauren will be speaking on Australian Immunisation Register and the changes.
Great. Hi, everybody. Thanks for having me. I hope you can all hear and see okay. So I'm just going to be talking about, not in too much detail tonight, but just issues around the Australian Immunisation Register. I just want to acknowledge, of course, the team at Assessment who have been providing me with some ideas and questions that they regularly get, as well as Services Australia, who was formerly the Department of Human Services, who recently had a name change, who assisted with some of these slides. As Mimi introduced me, I do work at the National Centre, but happy to take as many questions as I can at the end. Those questions that I can't answer, I am happy to take to Services Australia and get some advice back. So just a few things that I am going to cover today, just around the register. Oops, I just think I've just done something, just 1 second. Sorry, I've just, using the practice software, just some tips around PRODA, HPOS and delegations and what that means, and of course some information around 10A reports. So just in terms of the data, I guess this is probably not new for any of you, but the data on the Australian Immunisation Register is used for a variety of reasons, particularly for immunisation coverage and monitoring the effectiveness of vaccine programs that we run, but also for the policy and research that we undertake. But it also does identify parts of Australia at risk during outbreaks, but also probably something that you've been experiencing the last few years, things around the eligibility for family tax payments and childcare subsidies, and also to consider enrolment for childcare and school, and also for employment. So we need the data on the register to be as accurate as we can. So this slide here just paints a little bit of a picture of what happens at the register on a day. This day was last year in August. They were trying to get me an up-to-date slide, but unfortunately, as you can appreciate, a lot of the team there have been put onto other duties. They were put on bush fireworks, and now with COVID. But you can see there a large number of immunisations are submitted every day. So this was in August, so they're looking at about 36,000 coming through practice management software.
Hi Lauren, it's Mimi.
Oh yes, you can't see my slides, I just saw that. Just 1 second, I'm just trying to get back into hey. Is that better now?
Yep, your screen's back up. Thanks, Lauren.
Okay, sorry. So this slide here, as I was just saying, just demonstrates, how many vaccinations are coming through to the register every day. So around 36,000 through practice management, 10,000 through the airside, and some are manual. But interestingly, they're looking at over 3,000 pending transmissions a day, and that's where there's errors in the data. So this, as I said, was in August, but just as a sort of a flag, any day during the flu vaccine period, which is sort of happening right now, they're getting sort of around 152,000 vaccines submitted through the practice management software. And of course, that would be higher now, particularly with pharmacies delivering a lot of flu vaccines as well. So this is why, when you're looking at those kind of numbers, it's really important that we're getting the right information through when we can. So the airside has some really good functions, and for those who use it all the time, this wouldn't be nothing new to you, but for those who aren't regular users, it does allow you to view history. So if you've got somebody coming in that's not a regular patient, sorry, I've just hit a button there again. You can view history. You can print off a history statement. So if you've got families who are, new to Australia, trying to navigate the health system, it is really helpful for them that you can print off a history statement for them, and that will allow them to enrol in childcare and the like. Of course, updating vaccinations given elsewhere. including those overseas. It's quite helpful to do that online. You can record a vaccination encounter that you've given in your practice if for some reason your software is down or you can't access it at that time. If you have inadvertently recorded the vaccine incorrectly in your system, you can go on to the AIR site and edit the vaccination encounter. I'll show you some examples of that in a minute. You can send secure messages to the AIR team, and you can view due and overdue reports for patients. And you can also look at your practice's payment summary, so you can reconcile for those payments that you receive for completing a schedule, and to ensure that you've received all your payments for the patients that you've vaccinated. So this slide here just sort of gives you an example of when you're looking at the AIR site and you've logged in to a patient, how you might want to go about editing an encounter. So you can see here where there is an edit function, you can make those edits. And a lot of the phone calls coming through to the register is around edits. So it's really important that you can go in there and do that. But you just want to make sure that that is done within the month prior to receiving the payment for that, for your encounters. So once your payment has been received for that month, the edit function is no longer available, and you will need to email or call the register. So this slide here shows, you know, the site and when you might want to print off a history statement. So again, you go into the individual and you can go into their history, and that function there to print the history statements available there. So that's a really good option online. As I mentioned, you know, there's a number of reasons why you know, vaccines don't always get reported to the AIR, and there's a number of common errors. And this slide here just talks about those common errors, and particularly ones just to be sort of be aware of is that the antigen that's been administered is under the minimum age requirement. Now we know that for certain things, particularly around MMR, that's recently changed to allow people who are travelling. So you just need to make sure that if something has been administered too young, that it may not be considered a valid dose and they may need revaccination. So there's some of the common things that you just need to think about when you're recording. So practice software, obviously, it's changing all the time and you're getting updates all the time. But we know that in the last 2 weeks, you need to ask yourselves, has our practice software been updated? Because just recently, all of the practice software systems put out some updates to include the 2020 influenza vaccines, one of which is Fluad Quad, because that is a new vaccine, and so it wasn't on your practice software up until a couple of weeks ago. So in most cases, these updates are not automatic. So you need to have a look at that. Best practice is not automatic. So if you're using best practice, you do need to follow their advice and follow the link and update your software. Medical director, you can actually set up automatic updates. So you just need to check your own software and ZMed. So those are the dates when those software companies did release their updates. And you can do a quick check on your own system. If Fluad Quad is listed in your drop-down menu for your vaccines, then you know the update has been done. But if it's not there, then you do need to do those updates. So as Nick was sort of saying, the data on the register is really important, and we want to see how many of these patients aged over 65 are receiving that quadrivalent adjuvanted vaccine this year. So just making sure that you're doing that. So just a few tips around practice software, and this is nothing new to you all, but you know, just ensuring that you've got the latest update. Demographic details are really important. So the practice software won't send immunisation encounter information through to the register if the details don't match what's recorded on Medicare. So that's really important. We want you to use the immunisation tab to record the encounters. Please don't free text. This is the way the practice software picks up encounters and sends them to the register. Just checking that the vaccine name is correct. We did a study a few years ago and there was a lot of Influenza selected instead of Influenza hexa, particularly when you're doing catch-ups and you're not using the schedule in front of you. So just check the vaccine name's correct. And the sequence number is also correct. One of the important parts, sort of considerations about that, is that If you're seeing a patient where you don't have all of their history on their patient record, it is a good idea to include their history. Maybe that's written in their blue book, or it's also detailed on the register. Because if you haven't got a patient's previous history, and for example they had their 2-month vaccinations at a practice down the road, and they've come to you for their 4 months, and you haven't got their history in there, then that will automatically default to their first dose, and then that won't be successfully transmitted to the register. So it's a good idea to enter history. And of course, when you do enter history into your software, when you're clicking the given elsewhere, that means it won't be sent again to the register. It's only recording it for your software to be up to date. As Nick sort of alluded to, we want all vaccination encounters to be sent for all patients to the register. The one exclusion for that is Q fever. Q fever has its own register, and Q fever is not accepted on the Australian Immunisation Register, but everything else is, including HPV vaccines. And we'd encourage you to send your encounters or batches daily to the register. Don't hold off till the end of the week. The more frequently they go, the less errors that occur. And always check your send box just to make sure that they've all been gone through. Just specifically around best practice, as I said before, we encourage you to send them daily. It doesn't happen automatically. You do need to go to the utilities item and send to air. They just don't sort of magically get sent. Somebody does have to action that. And if you're using Medical Director in conjunction with Praxsoft, just make sure that there is a Medicare card number listed on the patient's record. Medical Director and Praxsoft do need that number listed to successfully transmit to air. If the patient doesn't have a Medicare card number, we'd encourage you to, the best sort of workaround for that is to drop that encounter from your batch and submit the encounter onto the air site directly by logging into the air site. DVA patients, the DVA number is not accepted by air, but they all actually do have a Medicare number listed and available, even if they sort of say, oh no, I don't have a Medicare card, I've just got a DVA card. And you can search for their Medicare number via PRODA, and just always checking those sent items in the software. So I'm just going to talk a little bit about PRODA. So I'm sure a lot of you are using PRODA, and you know, there's nothing to be scared about. It's actually a really nice, secure system, and really it is just that. It's actually an online sort of identity proofing system. So it authenticates who you are and that you should have access to these this patient information. So it's a bit like setting up a bank account. You go to the bank and the bank wants to know that show a certain ID and that you really are who you say you are. So that's the reason for PRODA, and it is coming in because it's a lot more secure way of engaging with the Department of Human Services, and of course accessing patient information on the air site. So it is just important to know though that everybody should have their own individual PRODA access, and there's also some PRODA accounts for organisations in certain circumstances, and we would encourage you to start moving across now to registering for PRODA if you haven't already done so. There's certainly a lot of support out there for that, and there's a lot of online information about registering for PRODA, and it's quite simple, and we'd encourage you to do that. So PRODA is really that first step of authenticating who you are, and then you are able to have access to HPOS, which is the Health Professionals Online Services, and then through HPOS, then you can access the air site. So this actually does replace logging into the air site with authentication files, which is problematic themselves. So this is much more streamlined way of doing it. And once you are set up and you've gone through those steps, you will have access to the air site. So I've just sort of written this next few slides with some FAQs. So, you know, obviously most of you used practice software, and as long as it's up to date, it's functioning well and it's reporting all your encounters to the register, which is great. But on occasion, and best practice in an ideal situation where you're looking at every patient's record prior to vaccinating them, you want to log on to the air site and just check that they have had everything that they require and that your records are also up to date. So as a GP, how do you access the air? Well, you all should be using PRODA, and GPs are automatically given access to the air site via PRODA that's then linked to HPOS, and so then the air tile will be available and you can link that way and log on to the air site. So then you can just look up a patient's name, or using their Medicare number, and their details will be available. For a practice nurse, so this has just changed recently. So for practice nurses now, you can start using the AIR and accessing the AIR site using PRODA and HPOS, and by having GPs giving you delegations to act on their behalf. So previously, you might have used the GP authentication file, which wasn't sort of appropriate, but it was done, or you might have had an organisation authentication file and you logged on that way. But now you can log on as yourself through PRODA because you've authenticated who you are. GPs can delegate access to you and you're acting on their behalf, but you will still be logged in as you. So for example, if I was a practice nurse, my name's Lauren, and I'm working for Dr. Smith, Dr. Smith has delegated access to me, but when I'm looking at the AIR site, I'm logged in as myself, and it's clear that I'm acting on behalf of a GP, and it will list that GP's name. So it's all tracked, and you will be still working under the Medicare Act in that way. PRODA for organisations is available, so that might be useful in some instances, but for the majority of general practices, delegations to practice nurses and practice managers is the best way. But PRODA for organisations is available, but that requires organisational registration, and you can't access the 10A reports through this method, and I'll get onto that a little bit later. And so while authentication files aren't being switched off yet, we are encouraging everybody to start transitioning to PRODA when you can, appreciating the situation that you're all in at the moment and having a lot of things happening. So I guess just the steps are that all staff should register for PRODA. You are given an RA number and keep that and your login details. And for those nurses working in different settings, and GPs for that matter working in different settings, that RA number is unique to you and it will go with you. So if you're working at one practice Monday to Wednesday, you still log into PRODA, and then you'll be able to select who you're working on behalf of in that particular day. So your uniqueness will travel with you as such. And for a GP, the next step is to link your PRODA account to HPOS, and your AIR tile will appear, and you can log into the AIR site and look at all that information that you might need. And for nurses, for GPs, you can then nominate a delegate. And then for nurses and practice managers, you can either accept that delegation, or you can actually prompt the delegation as well by requesting a delegation to AIR. And all this is what it looks like, the AIR delegation screen. It's a little bit complicated looking at there, but there is some good advice on the Services Australia website. And Mimi and Brooke at CESPN can certainly help you through those processes. So just another question that often comes up is that, should nurses and practice nurses and practice managers acquire delegation from each GP in the practice that they are working? Well, ideally, yes. That each of the GP, does provide delegations. And then if a nurse is acting on behalf of one GP one day who would like them to edit an encounter or record an encounter on their behalf, that way the nurse or the practice manager can select the GP that they're acting on behalf of. So ideally, yes. I know it's a little bit fiddly to start off with, but once they're all in, then that's a great way of doing it. If you're a GP, how can you send a secure email to AIR? Well, there is a HPOS messages tile, and that's the way to communicate with AIR. And the best a great improvement in this function is now that you can attach files, and just like an email, you can attach things to that message. That previously wasn't available on the secure email site. If you're a nurse or a practice manager, how can you send a secure email to AIR? Well, the medical practitioner who's delegated access to you just needs to tick the My Mail box application there, and then therefore you can then be acting on their behalf and sending mail that way as well. And that there is the link to the Services Australia website. If you just Google Services Australia Managing Delegations, all of that information and the prompts of how to do that are available. So one of the, I guess, big questions is how can I identify children who are overdue coming to my practice? And years ago, when I worked at the Medicare Local and the PA, well, prior to that, slightly before my time, but the divisions of GPs, you used to get what was called the 32A report appear in your mail every month with a list of your children. But that information is still available, but it's now available online, and you do need to request that on the AIR site. But the good thing about that is that it is a list of all children who have come to your practice who are overdue. You can limit the parameters by just children who have visited your practice in the last 12 months or by any particular Medicare service period. And it also identifies children who you may not think are overdue because your practice software doesn't say that they're overdue, but for some reason they're being pended by the register. Perhaps their antigen was a repeat antigen, or dose, the minimum dose interval was too small, and it will identify those who are pending. So this screenshot here just shows sort of how to request the report. That's in the main menu item on the AIR site. But Assessment have got some great documents there, information sheets on their website about how to request a report and how to analyse a report. It does come as an Excel file, and you do sort of need to just get used to it a little bit. But once you've done it sort of the first time, it lists the children and the antigens that they're due for, and then you can check that against your practice software. And in some cases, they may have had those vaccines and the information is just not correct, and you can update that, or then you might be able to then recall that patient. But the team there can assist you with support for running 10A reports and analysing those. And one reason that you might like to do this is that you might, if you're a practice that's getting some questions from phone calls from families to say, I've just received a letter from Centrelink to say that I'm not up to date with my vaccinations, but they've in fact had those vaccinations, you can have a look on the AIR site and ensure that any errors that have gone through are resolved before having to receive those phone calls, because it can be quite distressing for families. So I guess the key messages out of all of that is, keeping your software up to date, making sure that you're sending all information, immunisation encounters to the register for all individuals. Try and do that at the time of service or at the end of the day, but don't try and do it at the end of the week. The more encounters that are in one batch, it can be problematic and hold up the whole batch if there is one error in one of those encounters. If you can, we encourage you to check your patient's history on the AIR site, ensure that the correct information is entered in software, and start accessing the AIR site via PRODA and HPOS, and have a think about and have a sort of a play around with requesting and reviewing your 10A reports. It does really help. So there's just some contact details. Obviously, the PHN is certainly able to help you. There's a lot of information on the Services Australia website, the AIR site, and of course the AIR online help desk there as well if you need to speak to them. So I'll stop there, and I'll just stop sharing my screen there, and we can take some questions.
Hello. Hi, Lauren. Great. I might ask Nick to come back as well. There's been more questions that's coming through.
I'm not sure if Nick was staying on. He is involved in some COVID studies at the moment, and he was dropping off online to dial in, but I'm happy to try and answer them, or I can take them on notice.
Okay, no worries. So we start with the questions for Lauren. Can PHNs access AIR data, especially for vaccines other than childhood vaccination?
Yes, so the 10A report, so you can actually access data that is from your practice. So in the 10A report, you can look at due and overdue encounters, and you can set the parameters. So you're looking at all different age groups. So you can search all the encounters that you're given. But your practice software will also give you a list of encounters that have been delivered at your practice. So you can go into your sort of sent box and run a report of immunisation encounters given, and you can have a look that way as well.
Thank you. And for the next question, children without Medicare card, are they entitled to funded childhood immunisation?
Yeah, that's a good question. This came up at a webinar a few weeks ago. So free vaccinations are offered to those who have entitlements under Medicare. So they don't necessarily have to have a Medicare card, but there are some entitlements, and it's quite a detailed explanation. So I think what I'll do is I'll send the link that's on Services Australia website, which details all of that, because there are reciprocal arrangements between different countries. So in some instances, a lot of children who don't have a Medicare card are eligible, but in some cases they're not. So it's a very good question, and I'll get that link to Mimi to go out with the evaluation or a follow-up email. But the details are on the Services Australia website about eligibility for free vaccinations. And it's just a little bit complicated depending on reciprocal arrangements with different countries.
The next question is, if a parent refused their child to be vaccinated and the conscientious objection form was sent, the patient's name is still appearing on monthly overdue lists, how do I remove the patient's name from the overdue list?
Okay, so a couple of things there. So the conscientious objector form is actually no longer available. So being an objector to vaccination is no longer a valid reason not to receive a vaccine and an exemption. So families who are trying to complete that form, it's no longer available and it's no longer accepted. People can certainly choose not to be vaccinated, and that's their own individual choice. But there are then limitations on being able to enrol in childcare and in and receiving family tax benefits. So those children will always appear as overdue on your list, unfortunately, because they are always considered to be overdue. So you can maybe just make a note of that. So in their patient notes, not to follow up. But you know, there is some really good advice on the sharing knowledge about immunisation website that Nick flagged, the Sky website, which is talking about immunisation, and always leaving that door open for families to have the discussion about vaccination. But a conscientious objector form is no longer available. It hasn't been for a couple of years. So that child will always be truly overdue unless there's a medical reason, and there are medical exemptions forms for particular medical conditions.
And the next question is, if you work at multiple sites, do you need a separate PRODA account for each workplace for both practice nurses and GPs?
No. So once you've registered for PRODA, that is just to prove your identity, and you'll get a unique RA number. So whenever you log in at different practices or wherever you may be working, you might be working in a community clinic, you can still log in with your PRODA details that are unique to you. But what you will receive then is the ability to drop down on the drop down menu on which practice or which GP you're acting on behalf of, and that option will be available. So it's one login. So wherever you are, it's one PRODA login, but you'll be given the option of either logging in, acting on behalf of a certain organisation because they've delegated that access to you, or different GPs in different settings. So good question, but thankfully it's one login.
Another question is, does the PHN still provide overdue lists, or do the practices have to access the list themselves now?
So Mimi, did you want to answer that?
As far as I'm aware, the reports have to be accessed at a practice level. I do believe that previously the PHN would provide the overdue list, but for now I believe that only the practice can access their own list. Is that correct?
Yeah. Well, I guess it's a resource issue too, isn't it, Mimi? So, you know, I'm sure the PHN will support practices through extracting those lists and knowing how to do them, but you know, and maybe help you the first time. I think it's on a case-by-case basis, but just depending on workload at the time, we'd encourage, I'm sure the PHN would encourage every practice to try and do that themselves with support in the first instance. So
just going back to some of the questions that came through after Nick's presentation, if you're happy to answer, Lauren.
Yeah. Look, I'm not clinically trained, but if it's something that I come across and is clearly outlined in the handbook, I am happy to answer those, or, as I said, take them on notice.
Question is, what is the difference between flu quad and afluria quad?
So not the adjuvanted flu quad. All of the strains that are contained are all the same. So it's just the difference is the different vaccine company that's provided them. So the flu quad that's the adjuvanted is obviously different because it's an enhanced vaccine, but the strains that are contained in all the other vaccines are all the same.
The next question is, do newly diagnosed at-risk patient received Prevnar 13 followed by Pneumovax 23 for free under 65 years old?
Yeah, look, I think I'll take that one on notice. As Nick was saying, pneumococcal is very is quite complicated. So you'd have to follow the directions what's in the handbook. But if it's recommended in the handbook, and it was generally detail what is available. The other thing for those patients is that there's a really good pneumococcal calculator. And if you just Google Pneumovax tool, you can type in all the details of what that, it asks all about risk conditions, the age of the patient. So you can type that detail in. You can type in their previous vaccination history relating to pneumococcal disease, and then it will give you details of what's recommended. It is linked to the handbook, and it will also identify what is funded and what's not funded. But I'm happy to take that question back to Nick as well. But that Pneumovax tool, you can Google Pneumovax tool. That's hosted by the Immunisation Coalition, but it is linked to the handbook, so that will give you some good advice. As Nick was saying, with the changes inherent that are coming around pneumococcal vaccine, there will be some guides developed around decision-making tools to assist people, because it is a complicated space.
Another question is, can a patient receive Pneumovax 23 if the patient is on methotrexate?
Yeah, I'll leave that question. I'll get back to you with that answer on that.
Currently, private Pneumovax is not available since 2019. For patients with diabetes, can we offer free Pneumovax if they are under 65?
No. It's only recommended at age 65 unless they're Aboriginal or Torres Strait Islander. But you would have to check the handbook and get some advice back to you about that if they meet those at-risk conditions to have it at 65. But that's where the recommendation is at.
And another question about Pneumovax. Are the different categories A, B, C defined in the section about Pneumovax, so we know which patients need which schedule?
Yes, they are. So category A, and so it's category A and B, and that's detailed in the handbook. And there will also, they're trying to simplify that moving forward with the next set of recommendations. So if you had it's not sort of publicly available now, but there was the stakeholder consultation document that went out to try and sort of minimise those confusions in those categories. So that will be changing, as Nick sort of suggested.
The next question is about catch-up immunisation. If a patient is between 7 and 15 years old, they've had 2 doses of MMR and 3 doses of Hep B overseas, but serology shows no immunity to measles or Hep B, do the patient need 2 more doses or just 1?
I'd have to have a look at the handbook, but that is detailed in the handbook about the recommendations following serology. So we'd have to go back to the handbook, and I don't want to mess my computer around, but I have to have a look at what's written in the handbook. But if you go into the handbook, particularly into the measles section or the Hep B section, that will be detailed in there. So Immunisation Handbook .gov.au, and just on that, the handbook will become an app in the next couple of months. It will come back as will be coming out as an app as well, so you can use that on your mobile devices quite easily as well.
And one last question, Lauren. If brachial neuritis occurred with a vaccination in the past in an adult, and they have been avoiding vaccines since, what is the recommendation regarding flu vaccine?
Yeah, I think I'll have to take that on notice as well, Mimi, and I'll get advice back to you on that.
Yeah, we can email all these through to you, Lauren, and then we can email it out to the participants.
Yeah, that's fine. Yeah, we'll try and get responses back from the NCIRS team tomorrow on that, and I'll try and get them to you ASAP.
Perfect. Thanks, Lauren.